Dr. Ross Moy.
Hello.
We're recording. Mate, welcome to the HR studio. And I think let's kick off. I'm interested.
Okay.
In your experience as an army doctor,
Yeah.
and the experiences you told me about already, which was more challenging for you? Was it being a doctor
Yeah.
at a prisoner of war camp, or was it being a doctor on the MERT?
Oh gosh. Definitely different challenges, I would say. So I was the doctor for what was then the Divisional Internment Facility in Iraq on Optelic 9. So that was 2006, 2007.
Pull that mic up for me.
Yeah, no worries.
Yeah.
And yeah, that was ethically really, really challenging. It wasn't very physically challenged. It wasn't very dangerous. I mean, we were getting rocketed a bit, but it wasn't, that nothing like the guys in the city we're dealing with. But the ethics were really interesting and really challenging. So I was a brand new baby doc, pretty much straight out of training. I was the first full-time holder of the job, and I pretty much had to design what I did as I went along. So we had a fair number, over 100 internees who were of various legal statuses. Some of them were proper prisoners of war, but most of them were on they were interned for protection of the coalition forces. And
Explain that.
so, as I understand it, I'm not a lawyer, is my disclaimer on that one. So, because they were not uniform combatants, they could not, under the Geneva Convention, be considered prisoners of war. However, we applied as a matter of policy. We held them as if they were prisoners of war, but their legal status was slightly different. They weren't convicted criminals, but they weren't prisoners of war. They were interned, so that meant the GOC held a sort of a secret, I suppose, a command council where he would review intelligence evidence. So it wasn't evidence that would stand up in a court. This was evidence that they were perceived to be a threat to coalition forces, and so their continual detention was authorised on that basis. And I believe there was some legal agreement between ourselves and the Iraqi government about how that would work. My job was to be their doctor. So I'd kind of come through training expecting to be a regimental doc. So I was expecting to be off with an infantry or an armoured regiment and being their doc to 400, 600 healthy, fit guys and girls doing their stuff. And then all of a sudden I was looking after a bunch of middle-aged Iraqis, working through interpreters, guys with chronic health problems, and also a lot of it, there's lots of physical problems, there's lots of diabetes, lots and lots of other issues there, but lots of psychological stuff. These guys weren't psychologically well. We had all sorts. We had some really properly nasty people who'd definitely sort of masterminded unpleasant criminal activity. I obviously have no idea what these guys had actually done. As the doc, I find the easiest way to keep your head clear on this stuff is just not to know. So I knew what category they were held under. There were 4 categories of risk. So I knew the high category ones were probably real bad ones, whereas the lower category ones were probably just unlucky and on the wrong street at the wrong time. I never really knew, and I never really found out. So these guys, yeah, they were, but the ethics of looking after them was really challenging, because these were the guys whose pals were all lobbing rockets at me every night, and who were trying to kill, one of my best mates was RMO to the Duke of Lancs regiment in the city at the time. So he was out every night with all these guys. Their mates were having pops at him, and I was, trying to give the best medical care I could to his friends. And that was, I found that really, really tough. You're kind of having to keep your head on you're there to be a doctor. You're there to do a good job for your patients. You're there to advocate for them. So you're finding yourself asking for better food, better conditions, trying to make sure that they're being looked after in a humane fashion, while all the time their pals are out there trying to hurt your friends. So I found that really tough. And there was lots of organisational bits. For example, we were inspected by the International Committee of the Red Cross. So my job was to make sure that the medical care was to a standard that they were happy with. And I think pretty much actually when they came out, by and large, it was. So I was pretty chuffed, big tick, VG. But still, there were definitely days, I suppose everyone has ethically difficult days on tour, but they're usually not ones like that. It's usually when other bad things have happened and you're kind of processing that, whereas I was sort of processing the slow burn stress of having to look after these guys day in, day out. So that was pretty tough, and there were definitely days when you just catch yourself going, I'm on the verge of saying the wrong thing now, I'm going to go off to the gym, I'm just going to go and not be here for a little while. Luckily my team were really good, and they sort of they kept me going and kept me on the straight and narrow.
Yeah, I don't think most people do have ethically ethically challenging days on those tours? I don't think they do, because they don't have to face the challenge that you're talking about there. So talking about it from my own perspective
Sure.
on the ground,
Yeah.
you know, creating your casualties or creating your prisoners.
Yeah. Yeah. Yeah.
Right.
Giving me work to do.
I would never have to deal with, apart from the immediate care of a casualty, an enemy combatant if we'd injured or whatever, injured them,
Yeah.
then dealing with them there, and that would be, it wasn't. I never found that ethically challenging, because it would be a case of that's what you do. You keep them alive, because the value of intelligence is
absolutely.
paramount, right? And so I think that's where sometimes civilians who have a complete a misconception of a soldier or a sailor's or an airman's motive to help keep an enemy combatant alive, someone who's just been trying to kill you alive.
Yeah.
But it's because if you value intelligence, you don't get intelligence from a dead person.
No, you don't.
But going back, no, I don't think we did have ethically challenging days, because they would just move through the chain away from the front line and back to where you are. Talk to me about the health the ailments that they had. So you talked about a lot of physical illnesses, a lot of diabetes. Talk to me about that in contrast to what your experiences of normal Western world developed country stuff.
I mean, in terms of the NHS, the NHS practice I do, I mean, that's just standard. We deal with an ethnically diverse and physically diverse population, because I work in the NHS all the time, so I see everybody. But when you're working as, my next job after that, I was regimental doc for the Queen's Royal Lancers, so I had 450 cavalry soldiers who I can count on one hand the number of guys and girls within that unit who had complex, chronic, long-term health problems, and they were often as a result of previous injuries they'd had in service or just unlucky. Whereas most of the Iraqi internees had either significant physical or significant psychological ailments, just because, well, partly because some of them have been held for quite significant periods of time without trial. That's pretty stressful. These guys aren't convicted criminals who've had a trial and serving a sentence. They're held because the general considers them to be a risk to our forces. So there's no idea when they're going to get out, or if they're going to get out. They were, I would say, generally pretty well treated by our guys. We had the facility was run by a Royal Artillery battery. They provided the guard force, and they provided the security for the place. And then we had some SMEs came from MCTC in Colchester, and they were our detention experts. So their job was to make sure everything was done to an appropriate and fair standard. So I think these guys were quite well looked after generally, but you can't deny that they lived a fairly precarious existence. They didn't really know what they were doing or when they were. Most of them had been picked up on the back of a detention op by infantry soldiers, and hadn't really been, had never really had much else. They did get to see their families, which I think was quite.
They did?
Oh yeah. They got to see more of their families than I did, which was quite nice. Every couple of weeks, their families would be allowed to come in, and they would have a sort of sit down.
You're really struggling with that, Mike.
Yeah, I really am. It's trying to shove me through the wall.
1 second. Right. You come forward into that.
Shall I come forward into that? There we go. Right. Sorry about that.
Yeah. Go on. Sorry.
Go on.
Yeah.
That's better.
Right, go on.
Yeah. I suppose the difficulty with that is that a lot of the stresses aren't things I can help with. As the doc, you can help with. You can help with people's chronic problems. You can make sure their diabetes is well looked after. You can measure their blood pressure. You can do all this sort of stuff. But a lot of the stuff that was stressing them was stuff I had no control over. I couldn't just sort of ring up the general and go, "General, by the way, this guy's having a really shit time. Could you just let him go, please?" That wasn't going to happen. So my job was to kind of be the supportive guy. I suppose it was they didn't have really a padre, but I suppose that was a lot of what I was doing was basically giving them a place to vent, somewhere safe that they could come and have a shout off to me at. But working through an interpreter, that's really difficult, because there's so many cultural nuances of what things that mean to them, and through the interpreter they just get lost in that translation. So it's really difficult to figure out what it is that they really want of you. I suppose the other interesting thing there is medicine, the way people experience symptoms is a real cultural thing to it. So for example, in the West, if we're feeling stressed, we tend to just go and say, "I'm feeling stressed." And I think that's something that's changed a lot in recent years. Whereas in some countries, that's quite difficult. People struggle to express that in a way that makes sense to them. So they do what we call in medicine somatizing. In other words, they'll come to you with a physical problem. Say, "I've got a headache," or "I've got a stomach ache," or something like that. And that's not really because they've got a problem with their guts or a problem with their brain. That's their way of expressing their stress. And that's quite difficult to work your way through. You know, we do see it quite a lot with Gurkhas, for example. It's a sort of culturally appropriate way of saying I'm stressed or I'm depressed. Whereas, you know, you or I, like I say, the West has got much easier in terms of communicating when people are struggling with their mental health. Whereas around the world, that's still pretty unusual. A lot of places simply just don't really understand the concept of mental health and stress. So it all comes out in terms of a physical ailment. And that's quite dangerous, because if you end up chasing what you think is a gut problem, whereas actually the problem is the guy just needs to have a little bit of a rant and he'll feel better, then you can end up hurting people by doing too much medicine to them when that's not really what they need. They just need.
That's really interesting. So just try and understand this. Is it that they're pretending they've got so they actually have got not ill health.
Yeah.
They're experiencing discomfort in their stomach or their head or whatever, but that is how their body expresses.
Completely. Yeah. So there's like a big difference between malingering, which is basically making stuff up. That's the kind of, it's 10:30 on a Friday morning, I really don't want to go and see PT. I'll just go and tell the doc my knee's playing up. That would be malingering, but that's actually really rare. These guys genuinely experience these symptoms, but it's not. That's their experience of their stress. They're not making it up. They're not lying. They're not trying to pull one over on you. That is genuinely what they feel. But it's helping them to understand that the reason they feel that way is not because of a problem with their bowels. The reason they're feeling that way is because they're stressed, anxious, upset, and helping them work through that. And that is a thing in the UK as well. But I think our cultural differences make it more challenging, and particularly, like I say, when you're working with someone with a different language. Because I don't know. I mean, I've never lived in another country. I speak bad French and bad English, but I've never lived in another country long enough to work there. But I think it's really difficult to understand mental health problems and the way that people express things in a language that's not your own. Even no matter how long you've lived there, I think it's really tough.
Yeah, interesting, because it's also down to people's level of understanding about mental health, right?
Completely.
And that comes from education, comes from the culture.
Yeah.
And then in some societies and cultures, is going to be, again, that sort of weakness aspect of it.
Yeah.
Is going to be,
absolutely, and that's definitely a cultural thing that I think it's been interesting watching that change. Certainly in the British military since I've been in, the idea that mental health was all caused by just weakness, and you needed just a couple of slaps and to man up and go for a run or do some kettlebells, and then that would sort your mental health problems out. And that's, I think we've been on a bit of a journey with that and understanding that these problems are real for people and that they're not sorted out as simply as that.
So, back to the question. Which is more challenging.
So, I went round at a bit of a wool gathering there, didn't I? I think the Iraqi job was more challenging in some ways. I mean, the MERT is different because the MERT is very immediately challenging in that it's very noisy, loads of vibration, there's loads of bang, 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 everything's going to happen. So you've got, and certainly when I was doing it, we were relatively close into Camp Bastion. So MERT originally was started off when people were getting hurt way up in Kajaki, way up in the northeast, and it was a long, long transfer to get them down. And the idea was to get good quality medical care to them as soon as possible. But as we started to draw down and withdraw from Herrick, the timelines became a lot shorter, which meant the trips became a lot quicker, and there was a lot more pressure to get stuff done super, super quick. And we got really good at it. We got so slick because when you got a team of 4 people who drill to do things every day, you can get really good at stuff that in the NHS would take a long time because you're organising disparate teams who don't do this stuff all the time. So the time pressure is a lot more, and the immediate stress is a lot higher, but the slow burn stress is lower, if that makes sense. In between jobs, you're pretty chilled out. You're left alone down the flight line. We were day on, day off, more or less, or a day at 15 minutes notice to move, day at an hour notice to move. And when it's not busy, actually, it's quite chilled. But so the chronic stress was lower, but the immediate stress was higher. I suppose that's a roundabout way. I'm not sure if that really answers the question, but that's kind of the way.
I know what you mean. I interviewed a guy called bloody Brainfart. He was RAF regiment. He was MERT. Oh God, I want to remember his name. He's a good lad.
Yeah.
What is his? Oh, Tom Martinson.
Yep.
RAF Regiment. He spent a lot of time on MERT.
Yeah. They were our force protection at the back of the aircraft. Yeah.
Right. Okay. Yeah. And he was it him that said it? He was saying that it might not have been him. Anyway, someone made the observation that the thing with the MERT is that you going out, when you go out and deploy with the MERT, every situation you're going into someone's worst day. Worst day you're going into.
Yeah.
And it really, when that was explained to me, I thought, actually, every day I was out there doing stuff, every day wasn't the worst day, like someone's worst day. Some days were someone's worst day.
Yes.
Some days were my worst day, right?
Yeah.
But not all the time.
Yeah.
And that level of stress, like quick stress, quick onset of it, repeatedly, knowing what you're doing, knowing you're going in to be the lifeline potentially for someone making it or not.
Yeah.
Incredibly challenging. There's any incident stick in your mind as like the most challenging that you dealt with in the back of that heli? I can't imagine trying to, especially at night, trying to treat people.
Yeah, the night stuff was interesting. Although luckily I didn't do too many jobs at night. I think when you have several casualties, I think that's the most troubling thing is when you've got more than one patient. Because when you've got one patient, we had 4 clinicians and 1 patient, so 1 doc, 1 nurse, 2 paramedics. And 4 clinicians to 1 patient. And pretty much no matter how sick the patient, 4 clinicians can do a lot very quickly. I remember picking up a US Marine Corps soldier who'd had both both legs taken off by an IED, and we had 9 minutes with him. And in that time, we managed to give him pack all his wounds up, tourniquet his legs, dress his legs. Get intraosseous cannula in, so give him some blood transfusion. So we gave him some blood transfusion, we gave him an anaesthetic, and we managed all that in about 9 minutes.
What cannula did you say then?
So intraosseous. So when someone's really, really shut down, when they've got no blood left in them, getting a venous cannula to give them drugs and medications and everything else is really challenging, and particularly when you're doing it either in the dark or when in the vibration and the noise of the lifter, it's pretty tough. It can be done, but sometimes there isn't time to have a couple of goes. So to do it quicker, what you can do is put a cannula into the humeral head. To use it basically looks like a drill, and you drill a cannula into the bone marrow there.
On the shoulder?
Onto the shoulder, yeah. You used to do it into the leg, but actually often we were dealing with people who didn't have any legs, so we learned to do it into the shoulder. And then you can inject drugs, blood, everything else you want through it. It sounds really brutal, but actually works really, really well. The only problem with it is it really hurts. So one of the reasons, generally what we do is put the cannula in. Actually, putting the cannula in doesn't hurt very much. There's loads of pictures on YouTube of people putting them. You can put them into the sternum or you can put them into the humeral head. There's loads of YouTube videos of people putting them into themselves. And actually having them put in doesn't hurt very much. But as soon as you inject anything in there, you're expanding the bone marrow cavity, and that hurts a lot. So generally, you'll see the YouTube videos and people will tolerate having them put in all right, but as soon as you start to put anything through it, that really hurts. So generally what I would do is, the nurse was on the patient's right, so she put one in that side. Paramedic, she put one in that side. And then they'd both be injecting blood, and I put one into the sternum there, and that would allow me to give drugs, particularly sedatives and anaesthetics. So generally I would put one in, and then the first thing I would give would be some sedative, a bit of ketamine, just to get them over the pain of having to have stuff injected into their shoulders.
I'd never heard of that procedure.
Yeah, it's really common. Thankfully it's not very common these days, but it was our standard of care for a long time with our really sick patients.
Were you pumping blood into the bone marrow?
Yep.
How much can you pump in? It can't be a massive rate, can it?
It's not huge. I mean, so normally when you put blood into a vein, you just squeeze the bag and in it goes. To get it into the bone, you need to generate a lot more pressure, and that's the rate limiting step. So what you end up doing is syringing. So you use a big syringe and you have to really shove really hard. So you'd end up, let's say, the nurse and the paramedic would absolutely digging out, shoving all this blood in. Whenever you used to see pictures of people coming in to dropping off patients at Bastion, and they'd be covered in blood. It was never the patient's blood. What can happen is if you don't have the syringe on properly, you generate so much pressure that if you get it wrong, you'll spray yourself in whatever you're injecting. So I've got pictures of Leachy, the paramedic I worked with. It looks like he's drenched in blood, but it's not the patient's blood. He's just got the syringe wrong and sprayed himself with the stuff from the bag.
How does the blood, right? Now, to give me a biology lesson because I've forgotten. How does the blood quickly get from the marrow to the bone to the bloodstream? That's incredible.
It's incredible.
The human body's unbelievable.
It's amazing. It's as quick as putting it into a vein. So if you put it into
the bone,
again, go on YouTube. You can have a look. You can see videos of people injecting a radiopaque dye, so you can have a sort of X-ray picture and you can see what happens when you inject it into the humeral head, and you can see it will go the veins drain straight out of the bone marrow and into the blood system. So as you inject, pretty much you will see the dye coming into the subclavian veins on the right hand side there, and it's straight into the bloodstream. So we can give a general anaesthetic exactly as you would in an operating theatre. We can do that through the bone. It's like I say, the only problem is that it really hurts. Otherwise, we do a lot more of it. It feels really brutal. You see people doing it. We do it in the NHS when people are really sick, or some people are really tough to get access on for various reasons. So we'll do it in the NHS, but you find in the NHS people are quite frightened of doing it because it feels really brutal. This idea of I'm going to take this drill and I'm going to drill this thing into you. Unless you're an orthopedic surgeon, is quite an unusual experience for most people. So you find people are quite sort of frightened to do it in the NHS, whereas we train CMTs to do it all the time, and it's just a sort of standard of care. Works really, really well. But it sounds mental, but it really does work.
Did you see any throughout your time, so on in your different roles with the military, and now obviously you've got extensive experience with the NHS? Have you seen anything, any procedures or any techniques or anything of the bodies of knowledge that came into service, if you like, with the military or whatever operation, and then you've seen them over time come into the NHS in some way and manifest themselves at like a normal local populace level?
Well, that intraosseous, for example, most of the experience of that came from the military. I mean, a colleague of mine, Ed Barnard, and I wrote a research paper on that a few years ago, which is now about how to use it to give an anaesthetic through, and that had never been done before. What else?
Intraosseous is called.
Intraosseous.
Intraosseous. How do you spell that?
I-N. Oh god, it's spelling bee. I-N-T-R-A-O-E. Oh no, I've lost it. Sorry, I have to write it down. Spelling's not my thing.
Intraosseous.
Intraosseous access. So that's definitely. I mean, that was originally quite commonly used in children who can be very difficult to get veins on. So there's a tricky age with children. Newborn babies have got very small veins, but you can usually get one. But the happy toddler with the big pudgy hands. I don't know if you've got kids, but my kids, when they were about a year, 18 months, they go through this phase of having really soft, pudgy hands, and trying to get a vein in them is a nightmare. So if they're really sick, we'll use an intraosseous cannula in them instead, and that's where the technique came from. But popularising use in the adults, or normalising use in adults, definitely came from the military. I mean, there's a few other things that have come. For example, we were one of the first to do pre-hospital blood transfusions. So previously, blood transfusion was only ever something that came in hospital, and to do that in the field it had been done in the Second World War. I mean, if you go back to the guys at Market Garden who jumped in there, they carried plasma, freeze-dried plasma that they could give, whereas that is sort of fallen out of practice. Whereas nowadays, when I work on the air ambulance, we carry 2 units of blood and 2 units of fresh frozen plasma with us all the time, and that's something that we used to do on MERT, and that's come into normal civilian practice. What else?
Why did it drop out in the first place? Because of risk, perceived risk.
I think perceived risk, and also I think people just forgot that it could happen. I'm trying to think where it went. I mean, so for a long time, the sort of standard of care for people who were bleeding was to give them effectively salty water, and study after study after study showed that this really isn't the best thing for patients. My colleagues are saying that salty water is best for cooking pasta. But for some reason, it just stayed the standard of care that someone who was bleeding should be given salt water. And actually, we know that that's really bad for patients. If you're bleeding and I give you cold salt water, what it'll do is it'll dilute your blood so it won't clot. It will make your blood more acidic so it won't clot, and it will reduce its ability to carry oxygen. So it's actually making you worse. And yet, for years and years, it was the standard of care.
Oh my God!
So nowadays, what we try and do is replace what's being lost. So when you hold up, if you see on the TV show, you see them holding up a bag of what looks like blood. It's not actually blood. It's packed red cells. So we end up having to give it as components. Giving whole blood is quite technically challenging. The NHS don't do it very often. But
why is that? What's challenging about it?
Because it's the way it's produced and the way it's managed. So when you go and give a unit of blood, it gets taken out your arm, gets put in a bag, and then it gets separated out into components because different people need different parts of the blood. So, for example, someone who's got chronic anemia because they've got a bleeding bowel tumour needs some red cells, so they'll get the red cells. Someone who's got abnormal clotting because their liver's failed will get the plasma. Someone whose platelets have died because they've got platelet suppression will get the platelets. So you split it up so you can actually do the most good with the unit of blood by giving it to several different people.
I did not know that.
But if someone is actually bleeding, then whole blood is what they need. But because the National Blood Transfusion Service don't deal with that very often, getting whole blood from your arm into mine in a civilian setting is pretty challenging. Now, it's something we do in more austere ops, and that's something we've been working on, effectively the walking donor panel. So if you've got a company of troops, we'll have people pre-screened and pre-checked, so we know what your blood group is, and we know that they've been screened for viruses, so we can take a unit of blood from a soldier and give it to someone who's bleeding. The French have done it in Mali. There's a fantastic paper from the Norwegians. So you think it would. So there was lots of worries about, are we going to degrade our soldiers' ability to fight by taking a unit of blood off them? Because you think, take a unit of blood and you're not going to feel very well. So the Norwegians did this fantastic study where some of their SF guys did a series of physical tests, had a unit of blood taken, and then did the tests again. And of course, you know what SF guys are like. They're such a competitive bunch at the best of times. They all actually did better on the tests after having a unit of blood taken off them.
Like that in the same day kind of thing.
Yeah, same day.
So the idea is that an incident happens.
Yep.
Patient needs blood.
Yep.
You're miles away from Roll 1 facility, whatever you call it.
Yep.
And you take blood from another soldier.
So you do that probably
on the ground.
You probably wouldn't do it on the ground. You'd do it in a light surgical facility. So if you had troops at reach being supported by their own MO, their own medics, but a long way away from anything that resembles a hospital, we can deploy a light surgical team, which is a team of, it depends on it. There's various configurations, but a small group of people that provides me as an emergency physician, but we'd also have anaesthetist surgeons, we have a biomedical scientist to handle blood and everything else.
Well, that's not light. That's quite heavy, isn't it?
It's quite. I mean, these things are all comparative. You know, the smallest field hospital is over 100 people. And ISOs and ISOs full of kit. So when we did Exercise Safe Syria in Oman with Tutu Field Hospital a couple of years ago, that's what we took. So that smallest field hospital is over 100 guys and guys and girls and over 100 ISOs of kit. So it's a huge beast. So these things are all relative. The smallest. So it's all a continuum, isn't it? So right up forward, you've got the team medics, the guys doing their own medical care, and then slightly back from that, you should have their own intimate med support. So they're the squadron, the company medics, and then the MOs who are generally GPs with extra training. The next sort of step up from that is MERT, and we can go really quite small. So the MERT we had in Afghanistan was a team of 4, but we can go to a team of 2. So I can go out with a paramedic, but we can still give blood transfusions, we can give anaesthesia and all that stuff. Once you get bigger than that, you want to do surgery, and to do surgery actually requires quite a lot of other people, because you've got these teams will have 2 surgeons whose job it is really to stop bleeding. So I can do lots of things with drugs and everything else, but I'm not a surgeon, so I can't reach inside your body and stop you bleeding. So only a surgeon can do that. But for a surgeon to work, you can't just send out one surgeon, one knife, because they're pretty useless. They need a whole lot of other stuff to work. You need an anaesthetist whose job it is to keep the patient comfortable. So their job is to keep the patient my anaesthetist colleagues would say the anaesthetist's job is to keep the patient alive and comfortable, while the surgeon does his best to ensure the opposite. So the anaesthetist's job is to carry on the resuscitation, keep the patient asleep and keep them stable, and that's in a sick patient, that's really challenging. So you've got 2 anaesthetists, 2 surgeons. The surgeons need a group of guys called operating department practitioners, and their job is to keep the instruments and the kit working around them, so that the kit is sterile and it's ready and it's good to go, so that when the surgeon's working really hard inside a belly to clip a bleeding vessel, there's somebody there to make sure that the kit is being passed in, as is needed. So all of that takes a lot of kit, takes a lot of people. So although we call it a light surgical group, you're right, by military standards, it's still pretty hefty. But that's about as small as you can go and still actually effectively reach into somebody's body. There's been a bit of work done. The Americans have been trying to work on this. Trying to go even lighter. I mean, they've looked at what they call surgical resuscitation teams, which go down to 4 people. But the trouble with that is, even those 4 people, as soon as you take it, you can project it as far forward as you like, but as soon as you've got a casualty you're working on, everyone is completely heads in, you're completely immobilized, and you're really vulnerable, and you're relying on other people for your local defense. You've got to be really careful how far you push that, because if you're in the middle of a fast-moving operation, and you're immobilized because you're busy cutting someone's belly open, then you immobilize everybody, and you make everybody really vulnerable. So there's only so far forward you can push that capability before you actually cause more harm than good. So generally what we're finding is, it's all about risk, time, transfer. So my job generally these days, moving away from the Afghan world, my job more is to support my colleagues in the Role 1, the RAP. We'll bolster onto the RAP and provide their back door. So they're looking forward at what the guys and girls are doing on the ground. We'll be in a sort of safe place, but well back from that, so that we can do our bits. We can make sure people are comfortable, give them all that blood product transfusion, all the extra drugs that we can give, and then we can handle the moving the patient sometimes several hours to get to a hospital if necessary, and the Royal One medics can stay where they are, looking after their own guys and girls.
Mm. What you mentioned the French in Mali. What did the French do in Mali?
So they've been doing some work with whole blood transfusions.
Yeah.
So that's that business of, like I say, the troops on the ground all being pre-screened, and someone gets hurt, they'll take a unit of blood from within the unit and transfuse it then and there. I don't know how far forward they're going with that. I think they're still doing that in static positions. I don't think you're quite at the stage of taking a unit of blood at the back of a warrior and sort of transfusing it in. But there's no theoretical reason why not, but I suppose it all comes down to the practicalities, like I say, of what else is going on and what other things are happening in the operation. Because the trouble with medics is we tend to think that we're really important, because I suppose, well, let's face it, we are. But actually, we're very much enablers. We're part of the G4 chain. We support the fighting troops, and at the end of the day, achieving the mission's got to be the thing that happens. So we can only work within that context. We can only work with everybody else to get stuff done.
Mm. What's it like being a doc at a regular unit like the Lancers? Always fascinated me, because I'm just thinking of the time with the docs at 3-power overtime and think, oh man, it must be a nightmare sometimes. Must be a nightmare. Must be the same for all units, right?
Yeah, I think every unit's got their challenges. I mean, I think I was really lucky, actually. I think the Lancers were a great bunch. I think cavalry soldiers are generally quite... I think the amount of silliness that went on was slightly less. My mate Phil next door, he had 2nd Battalion Duke of Lancasters, and I think he had a few more interesting characters who would do some, and then they did some amazing stuff. The thing that stuck me, the Lancers, they had great nicknames for each other. Sergeant Major Driver was known as Screwy.
It's known as what?
Screwy. Mr. Locking was known as Central. Captain Drew, who was known as Nancy. And one guy who was so ugly that he was known to the entire regiment, including the colonel, used to call this guy Muttley because he was so ugly.
Military nicknames are the best.
Yeah.
They're so obvious, aren't they? It's where's Tiny? Who's Tiny? He's not tiny. He's massive.
Yeah, he's huge.
Or Doghead.
Yeah.
Or Bullhead.
Yeah.
Why'd you call him Bullhead? Because he's got a head like a bull. Why'd you call him Doghead? He's got a head like a dog.
I've got a mate who's a retired W2 who's and I knew him as a W2, so big senior. I was a junior captain. He was a senior W2, so really important guy. You take this guy super seriously, but his name was Junior, and you're kind of struggling to this is this really important guy. I've got to take him really seriously. Why are you called Junior? Because I've got 3 big brothers, and when I joined, they just called me Junior, and it just stuck.
How's things been for you work-wise since the obvious flipping C word started happening?
It's been different. Sometimes good different, sometimes bad different. It's been busy. I think we in the emergency department have probably done all right generally. I think.
Sorry, so explain what you do now.
Go on. So I'm an emergency physician. So I work in the emergency department at the John Radcliffe in Oxford. So that's one of my. I've actually got about 4 jobs. So that's one of my jobs. My other job, until very recently, I used to fly as a critical care doctor with Thames Valley Air Ambulance. I'm just in the process of being posted, so that's changing. I also do. I'm the Carter emergency physician at 22 Field Hospital, so I'm there, in-house guy for emergency stuff, and I'm also the clinical director of MERT training. So my job now is to take people who are working on regular Army or Navy and RAF docs who are working on air ambulances in the UK, and I run a training course to sort of show them how to take those skills and then use them on operations. So we do a 2-week course at RAF Brize Norton to try and teach them how to convert their skills into a tactical sense, and how to manage combat casualties, but to the same standard that they would on their own air ambulance services in the UK. So those are my jobs, plus whatever else comes in every now and again. There's somebody else comes in.
What does that course look like, that 2-week course?
So what does it look like? So we do a bit of kit familiarisation. We do stage 1 drills on Puma and Chinook, and we sort of show people how to work on an airframe that's quite different. Because normally most civilian air ambulances use very small aircraft, EC-135, EC-145. So they're quite small aircraft, 1 patient, a couple of clinicians. But the difference generally is that on those really small platforms, I suppose Wildcat or Lynx is probably the closest military equivalent, you can't do very much in flight. So in Afghan MERT, we used to use a Chinook, which is the size of a bus, so you can basically get up and run around it, run laps around the thing if you want. Whereas, I remember coming back from Afghan onto this little civilian air ambulance going, this is ridiculous, what do you mean I can't get up and walk around? But obviously the model we use is much more permissive. It's very rarely that you're actually in danger at the point of wounding. The car crash has happened, the person's fallen off a building. So you'll arrive, you'll stabilise the patient, and then you'll transfer once stabilised, whereas obviously you can't do that in a contact. You have to evacuate as fast as possible, because I can't imagine the Chinook crew would be too thrilled to just stay on the ground while we'll just do a few more bits here. So the idea is to get on and off the ground as fast as possible and do everything in transit. So it's a very different model of care. So it's trying to teach people how to sort of think differently about how to deliver care in transit in a platform you can move around on. So that's that. And also the patterns of injury we see. Thankfully you don't see an awful lot of gunshot or explosive wounds in the UK unless you work in inner city areas. And even then, the wounds you see are very different, because most criminal person-on-person violence in the UK is small caliber weapons, and they produce very different injury patterns to high-velocity rifles. Thankfully, we don't see an awful lot of that. You see the occasional shotgun, but again, you don't see high-velocity 7.62 rounds going through people. And again, stand fast, the days of Northern Ireland, actual explosive injuries in the UK are really, really rare, thankfully. So there's a bit of remind and revise that we need to do to sort of teach people how to manage those casualties and just keep those skills alive, because obviously thankfully we're not in a kinetic war anymore. We're not seeing large numbers of casualties, but it's important that we don't lose the lessons that we gained so hard. We did get so much better during the Afghan years at managing these casualties. One of my colleagues in Oxford, a guy called Joan Penn Barwell, is a Navy surgeon. He's an academic. He's done some really interesting work trying to capture all these lessons, and he's produced this amazing graph that shows how much better, for a given burden of injury, how much better we got at keeping these people alive. So we can give people scores to sort of put a number on how badly injured you are based on what's happened to various parts of your body.
Survivability, right?
Survivability, exactly. And that's where we end up in this point of having patients who statistically shouldn't survive, and yet we've got a fairly large cohort of guys and girls who survived injuries from the Afghan days who shouldn't have, mathematically shouldn't have survived. And he's produced this amazing graph that just shows year on year how we got a little bit better every time. Because it's in beautiful colours, it looks like a unicorn's tail, so he calls it the magic unicorn slide.
It is incredible when you think you've got, people like Mark Hornbrot walking around.
Yeah.
He's got one limb.
Yeah.
And not only and other people who've got catastrophic injuries like him, multiple amputations, traumatic amputations, and not only being able to function, but being able to enjoy life.
Yeah.
It's like it's incredible. I think people do forget actually how awesome that primary care was, to be able to keep those people alive, and then also the aftercare, the technology we've got now that can just, again, enabling people to get the most out of their life, even though they're operating with less than a full body.
Yeah, I mean, it's funny, MERT's quite a visible thing, obviously, because we come on a helicopter and lots of people remember us picking up casualties, but actually we were a very small part in such a huge chain. People use phrases like life-saving, but actually we very rarely saved life, I would say. It happened occasionally, but generally the lives that were saved, it was the guys and girls on the ground, getting the tourniquets on, putting those dressings in, giving that pain relief then and there. They're the ones who really save lives, Once they're on the aircraft, our bit, actually what we're doing is we're starting off that rehab process. And I know that sounds crazy, but what we're doing is we're assuming that the medic on the ground, they've saved the life. We're starting off that process of getting them back to having a life. So by giving early anaesthetic, early good blood products, we're giving them over to the surgeons in a good state for their surgery. By giving them good early pain relief, we're hopefully reducing the psychological complications that people are going to get from being injured. So all of that actually has its effect really months and months later when they're going through Headley Corps, as is now the DNRC. That's the stuff that, as you say, takes them from the injured person to someone who's actually got a life that they enjoy living. And that's the really important part of what we do, I think. We start that process off, but it's a long chain, and it takes months and months and an awful lot of people, and we're just a very, very small part of it.
How much notice would the surgeons in Bastion get about having to conduct a potentially life-saving surgery, a complex surgery on someone?
Yeah, I think that depended on who brought them in.
Go on.
Generally, if it was one of our casualty evacuations, so we worked alongside the Americans. We would get dispatched to slightly different casualties. So the Pedro, and then later on the dust-off aircraft they were quicker off the ground, and so they could go to some stuff, but we had more capability, so we would go to the sicker casualties. But we were generally quite good at telling people we were bringing patients in. I mean, and sometimes what turned up wasn't entirely what we said was, but at least they would have some notice. If the Afghans next door would just bring in, we used to call they lived in Camp Shurabak next door, and they would bring us in what we call Shurabak specials. Basically, they would their approach to their approach to casualty management was very, very different. So basically, what would happen is they would put the casualty, sometimes with not very much care at all, in an ambulance and drive them around to Bastion. And basically the dude in the front wasn't a medic, he was just a driver. He would just sort of get into the ambulance bay and honk the horn. And we all developed this horrendous Pavlovian response to a horn honking. We'd all leg it out into the ambulance bay and open the doors. And sometimes you'd find a guy with a cut finger, and sometimes you'd see some horrendous things when you open those ambulance doors. So so they were the interesting ones. But the surgeons, generally, surgery has to be planned and thought through. You don't just dive on in with a knife. You've got to think quite carefully about what you're going to do. So we would try very hard to give the surgeons time. So our certainly in the emergency department, our job is to kind of bring some order to the chaos. We should get in a whole pile of casualties, and our job is to kind of sort out who needs what, be that from clinical examination or ideally from a CT scan, so then we can pass them on, so that we can sort of chat to the surgeons and go, okay, that one immediately looked the sickest, but actually what we'll do is we'll keep that one here and we'll give him a bit more blood, a bit more resuscitation, and he can go to theatre a little bit later, whereas that one is still bleeding and really needs to go under the knife right now, so we'll move that one into the operating theatre, and then they would work. So the surgeon's got a bit more planning. Our job was to act as a sort of a break and a buffer to give them a bit of headspace to think about what they actually needed to do, and then they could move the patients on from there. So it's all, I suppose, it's all to do with that team mentality, and then everyone having their own little role within it.
Mm. How long would you do in those? How long did the docs do in those rotations and the surgeons do in those rotations?
It varied. They try not to have us away for more than about 3 months, and there's a number of reasons, and that started off during the sort of Balkan days, and that was because people weren't doing very much. And the trouble with particularly surgeons and anaesthetists is that unless there's lots of casualties, they're not doing very much, and so their skills can atrophy. If you're not doing your job, you kind of forget some of the little nuances of it. You're not quite as slick, you're not quite as good. And we see the same thing. Emergency physicians, we've generally always got something to do, even if it's just minor injuries and some of the primary healthcare that we get involved in. So we're generally fairly okay, but the surgeons and anaesthetists can get quite bored and disruptive at times. But they say bored soldiers are a thing. Well, bored surgeons are definitely a thing. So we generally will go away for about 3 months, and that sort of kept going in Iraq and Afghan, and then simply because the intensity was so, when things were busy, the intensity was so high that we were burning people out, and so just to avoid people getting physically and mentally exhausted, they had to be rotated through reasonably regularly. These days we're trying very hard to stay back to that 3-month model, and again it's mostly because most of our ops these days are lower tempo. Thankfully we're not taking large numbers of casualties, but it means that skill fade is more of a problem again. So yeah, we generally try to keep it to about 3 months. That's about as much as we think is realistic. After that, I mean, even last couple of times I've been away, you come back after 3-4 months away, a bit of pottle, and you kind of, it's not that you forget how to do your job, but you just need a little bit of guided practice. So I generally will make sure that if I'm in the emergency department, I'm working with an experienced colleague, just to sort of take a few days to remind myself how the NHS is different from being on ops.
Yeah.
And it is.
So what's that like? Military GP, and you're not on an operation, working with the NHS. What you do? So
the GPs are slightly different. So the GPs generally work in med centres, so they're doing their job all the time. My job is predominantly in the NHS. Probably about 2/3 of my time is spent in the NHS, and the rest of it spent supporting. It's either get ready for ops of various kinds, or it's just, I support a lot of training. A lot of what we do is try and pass on our knowledge to other people and sort of support. I support other units. So for example, if one of my primary care colleagues, they want a bit of extra trauma training for the medics in their RAP, then I'll arrange to go and do that for a couple of days. So a lot of it is that kind of work. We're a bit of a scarce resource. There's not huge numbers of us. but a lot of what we do isn't. We can't be on ops. We can't be everywhere all the time. So a lot of what we do is try and pass on what we learn from the fact that we're dealing with patients every day in the NHS. We're dealing with trauma. Oxford's a major trauma centre, so I deal with trauma patients every day. Whereas a CMT in a med centre is predominantly doing primary care work. All about occupational medicine, all about getting people ready to deploy, vaccinations, or hearing checks, all of that sort of work. So they don't see an awful lot of trauma. So in order to get the most out of their limited time training, we try and go and support those exercises, make sure they're realistic, and make sure that they're, the markings is not just about what the book says, but what we know actually works in real life.
Are you uniformed at hospital?
I wear scrubs. Just because I wanted a job where I could wear my jammies to work, but I wear a little rank tab on the front of my scrubs. I think that's quite important. I think it's quite important that my civilian colleagues see, because there's quite a few military people in Oxford. Predominantly, we've got, I think in the emergency department we've got 4 or 5 military consultants, but we've also got probably 20 nurses in ED, ITU. We've got at least one orthopaedic surgeon, at least one plastic surgeon, got a couple of anaesthetists. So there's quite a few of us sort of spread through.
Why there's so many at Oxford?
Well, we're spread all over the country. We're predominantly working in major trauma centres, but Oxford has traditionally been quite a good place because it's near Brize Norton. So, for example, if we come under the Royal Centre for Defence Medicine based in Birmingham, but we are one of the alternate sites if for whatever reason a patient is brought back to the UK from overseas. They should go to Birmingham, but if Birmingham's full or can't accept for whatever reason, then Oxford's one of the extra places. But the reason we're also widely distributed, we used to have military hospitals, and they closed 1991, I think. Some of them kept going a bit longer, but the Options for Change review said no, these places aren't what we need anymore. They were good hospitals for what they did, but the problem was that they weren't giving us, the clinicians, the exposure we needed. We weren't looking after sick patients, we were looking after young fit soldiers. So our surgeons were doing hernia ops and varicose vein stripping for fit guys and girls, and that's not the stuff they need to be practicing for ops. So we all moved over into the NHS. But then that means that the predominantly what happened was people moved into hospitals that were near significant areas of military population. So for example, in Catterick, the Catterick Military Hospital closed and everyone moved into the local little hospital in North Allerton, but actually that's probably not the best place either. So predominantly people have now moved into Middlesbrough, which is fairly busy. We've got people in Plymouth, again, big naval centre, Portsmouth, big naval centre. The army guys are generally a bit more disparate because there's not, for example, like Salisbury Plain's got a big centre of army population, but there's not really a big trauma centre there. So some of us ended up in Oxford and other people ended up in Southampton. So we're sort of drifted all over the place. And I'm actually posted to Glasgow shortly, even though the Faslane's probably the nearest big military centre up there. But that's mostly to do with the opportunities to do critical care retrieval work, which I think is going to be really useful for the military going forward, because a lot of what we're going to be doing, I think, in the next few years is, well, hopefully we're not going to be doing peer-on-peer. Hopefully we're going to be doing, most of the stuff is small teams deployed at reach a long way away from hospital. And, as much as possible, that's still that MERT model of trying to bring the hospital to the patient, is that we'll be up there, in sort of relatively austere settings, but looking after those guys and girls who've been hurt and then moving them long distances to get to a hospital.
And that's your next job, the critical care.
Yes, that's the next job.
Critical care what?
Critical care retrieval. So,
retrieval. That's right. Yeah. Can you talk about that or not?
Yeah. So that's an amazing job. So we'll be working in an emergency department in Glasgow, but I'll also be doing the way that works is if you get sick or injured in the remote and rural communities in Scotland, obviously you can't have a big hospital everywhere. There's just not the population density to support it. So you've got lots of little hospitals, and some of those are managed by secondary care docs, surgeons and anaesthetists, but they're basic for a lot of things. They're one brick thick. So if you have a sick person who needs to be moved down to one of the bigger centres, you can't strip the resources away from the little hospital because there's just nothing left. So there's a team based, there's 2 teams actually based in Glasgow and Aberdeen, and if you get sick in one of these remote and rural places, we will get in we can go by car, we can go by fixed wing, we can go by helicopter. If the weather's rubbish, you can go by the search and rescue aircraft, which is really interesting. It gets quite bouncy at times. Sorry. And we'll go out to wherever you are, and if it's and we'll basically sort of fix you up, package you up, bring you into that aircraft, and bring you down to the central belt. So I think that militarily that's really useful. I think that's got a lot of things to offer from a teaching point of view. So I'm really excited about going on to do that. I think that'll bring a lot of good lessons into the military.
Yeah, that could include rigs as well, I take it, oil rigs.
Do you know, there's no reason why not, but I don't think we do very much rig stuff because but actually, possibly. It's I'm trying to think what you would do. I think with the rig stuff, probably what you would do is just load them on because most of them can get easy access to their own aircraft. They would probably just bring them back. But I suppose if there was a big incident on a rig, you could. Our kit could be loaded into one of their aircraft, and we could go out and bring a patient in. I've not really thought about it, but yeah, I guess it works in theory. Certainly, some of my colleagues have done. You've been to some pretty remote islands where there's not really very much, and I guess an oil rig's not that different in terms of capability, is it?
Yeah, probably have better care facility there, emergency care.
Yeah, you probably do actually. They're much more set for it.
Yeah,
they do certainly since some of the horrendous things that have happened on oil rigs. I guess they're quite used to people getting sick and injured, and they have quite a lot of prep for it because they're not necessarily. It's not easy sometimes to get off an oil rig, is it? When the weather's bad.
When did you start working at Oxford?
2015.
Okay.
So the train time, the training time is enormous. I mean, I started medical school in 1998, and I only became a consultant in 2015. So it takes a long time to get to the end. Yeah, it's been a good run though. Oxford's a good place to be.
Yeah. So talk to me about the experience through COVID. Obviously, there's been a lot of interesting your perspective.
Yeah.
Lots in the news. Lots of experiences. I've interviewed a nurse who's she's a jock actually. I can't remember which hospital she's in. Interviewed a nurse last year through the pandemic, talking about her day to day and the pressures and all the rest of it. So talk to me about that from your experience.
Yeah, it's been interesting, and I don't think we've had the worst of it, to be honest. I think my colleagues in critical care and respiratory medicine have been hit really hard. They've had a lot of very sick patients to manage for a long time. I think our part of it's been relatively, it's been busy, but we've not seen a lot of the normal work we see, because of lockdown. People haven't been out getting drunk, they haven't been out smashing their cars up, so we've seen a lot less of what we would consider our normal business. So actually, I would say our workload's been about the same, whereas theirs is, it's just been different, whereas their workload's gone up.
Has any changes been unexpected? Has anything changed, like increase in incidence of whatever?
Yeah, I mean, it's been you've been seeing a lot of things that we haven't seen for a long time, because we've seen, usually, for example, you get chest pain, you ring an ambulance, you turn up to hospital. But we've had people who, because they're for whatever they're frightened to go to hospital, have been delaying asking for help, and that means we've been seeing late complications to heart attacks and things that I haven't seen for years and years. You get certain conditions when a heart attack's not treated early enough that I hadn't seen for a long time, and you've seen a bit more of that.
Like what?
So you can get there's a condition where you get fluid forming around the heart as a late complication of a heart attack that's not been treated early, or you can actually get the heart failing to pump properly. If you get a heart attack, you get a restriction of blood flow to the heart muscle. So we can find that on an ECG, or the paramedics will find it on an ECG. They'll take you straight to the cardiologists who can open up that blood vessel and restore the blood flow. But if that doesn't happen quickly enough, that bit of the heart muscle will die. And if enough heart muscle dies, your heart won't pump properly. And I hadn't seen that for years and years, because generally these people present straight away and get sorted out, and it's not really a drama. So we've seen a lot of that. We've seen a lot of late presenting stuff, because the whole healthcare system's had to completely switch fire to COVID. Lots of what we consider routine business hasn't been carrying on, and people have not had the same access to healthcare they've had normally. So conditions that would have been managed one way have been basically put on hold because of COVID. So we're seeing a lot of people with, for example, really bad arthritis who would have had a knee or a hip replacement have had to wait months extra, because all the operating theatres and all the surgeons and all the anaesthetists that would have been doing that have been redeployed. I've had some of my colleagues in orthopaedic surgery in London, for example, have been helping out in intensive care units, and that's completely not what they're trained for. But there's no chance anyone's going to be doing routine joint surgery in the middle of a pandemic. So they've all been reallocated, and so there's a long wait, and that means people are getting sicker waiting for treatment that they would have had otherwise. So that's been probably the biggest downside. I mean, on the plus side, I would say there is a saying about never letting a good crisis go to waste, and I would say that some of our ways of working have gotten a lot slicker because of the pandemic. Because hospital medicine has a tendency to get a little bit about silos, about this is my little bit of turf and I'm going to defend it. And something like a pandemic suddenly forces everyone to see themselves much more as a part of a whole rather than an individual service. And so there's been I think generally it's been a lot more team working, and that's been really good to see. And what's been really nice, actually, particularly one of my colleagues in Oxford has been heavily involved in sort of trying to bring some lessons from the military into the command and control of the NHS about how to run a hospital more like a military unit, having an ops room with a sort of, central information hub where you're bringing in information from others, but a bit more central direction rather than just letting every unit run itself as it sees fit. Which it's been interesting to see how things can change for the better when everyone's really busy and everything's really tough.
Yeah, that's a good point. I hadn't thought of it like that until you mentioned it. They don't. They're just a bunch of departments with no central, not nervous system, but CPU controlling everything. Yeah, and the resources and all of that. Yeah.
So that's been, like I say, I think although it's been pretty tough, I think some good things have come out of it, and we have, I suppose, like everything, operations are tough and they're miserable at times, but you generally come back hopefully having learned something. So there's been a bit of that. I guess the biggest thing going forward is going to be that people are tired, and it's going to be what happens next. How much longer this all carries on. Hopefully the rapid vaccination rollout will make it better, but we've just got to see, I suppose.
Yeah, it's going to be interesting to see what goes on, and see what the retention rate is like of all of these extremely experienced nurses and doctors and healthcare professionals.
Yep.
See what the retention rate is like over the next few years. I mean, sort of using military period of 2000 to 2011, 12, 13, 14, there was the retention rate was really low. People were they were doing what they joined up to do, and then getting out.
Yeah, they were like, I've done my bit, I'm off now, thanks very much.
We lost bags of experience, bags and bags and bags of experience, and it caused, you still suffering the repercussions a little bit now.
I think we are, because these are the people who previously would have stayed and become our best senior NCOs and sort of mid-level officers, and they've now gone off to other things, as you say, because they've done what they came to do. Thanks very much. Thanks, got the memories, got the T-shirt, seen the elephant, and now I'm off.
I wonder if we'll face a similar thing with the NHS. Maybe
I don't know.
It's quite possible. People are burnt out, aren't they?
Yeah.
And not just the NHS. No. All the frontline services.
Everybody's tired.
Right.
And I suppose that's the other thing that yes, we're busy, but my colleagues, paramedic colleagues in the ambulance service they've borne the brunt of a lot of this because again, because they're so busy and we're seeing people dying suddenly, there are huge amounts more cardiac arrests, which are quite stressful to work with. Our colleagues in the police have obviously had a pretty tough time with it. It's been really hard. It's been hard for everybody, and well away from the emergency services. I suppose what's interesting is you realise just how many people don't really think about, but actually are essential. The guys who put groceries on the shelves in the supermarkets actually really are key workers. Teachers, these people are absolutely key workers.
Bus drivers, train
completely.
drivers.
Yeah, absolutely.
Postmen.
It's amazing how many people are out there that people just sort of you just take them for granted until all of a sudden they're not there, and you think, actually there's no beans on the shelves. That's not good.
Amazon, Deliveroo, Just Eat, it's all of them.
Yeah,
it's
absolutely.
unbelievable.
Yeah.
I tell you what, there's a like the delivery services.
Yeah.
They're riding this wave.
Yeah.
Amazon, every 2 seconds. How many? I'd love to see a graphic of how many Amazon vehicles are on the road delivering. It is crazy.
Must be thousands.
Crazy.
Yeah, absolutely.
And what did I hear about the other day? Deliveroo being the new way of getting the drugs to your front door.
Yeah, I tell you
Have you heard that?
No, I haven't seen that. Is that Deliveroo as in like medicines or as in illegal drugs?
No, illegal drugs.
Wow.
Because it's been hijacked by drug dealers and people who want the drugs. Because how else can?
Yeah.
It's very difficult to go and get away with stuff because you're more obvious on the street.
Yeah, completely. I suppose. There was definitely a time in Glasgow where it was all ice cream vans. The drug distribution. Yeah. In the 70s, they talked about the ice cream wars, where basically drug dealers would use ice cream vans as a way to circulate drugs around. But people were obviously shooting other people or stabbing other people for going to the wrong ice cream van. Yeah.
Are you looking forward to going back to Glasgow? What's it like these days? It's had a bad rap, hasn't it?
So
different periods of time.
Glasgow's an interesting place. So I'm actually from Edinburgh, so I probably should, I should probably be a bit down on Glasgow. I should be a bit snooty, but actually, they're a better laugh. It's a really fun city. The people there are. There's this sort of
Glasgow or Edinburgh.
Glasgow,
yeah.
There's this sort of strange culture of you may break my feeble body, but I will have one last joke. There's a whole city of comedians. They're absolutely absolutely hilarious.
Yeah.
What else is fun? I mean, it's a good place to work. It's a good place to live, and it's kind of near home, you know. And I've been up, as most military people, I've kind of been dotting all over the UK for years, and it'd be quite nice to be a bit nearer home, you know, see a bit more of my mum, get some home cooking. Yeah, it'll be like lots of things. It's always changes, and upheaval is always tricky, but I think it'll be good once I get there. I think the other thing about Glasgow, and it's interesting, is, you know, every person in Oxford I said, "Oh, I'm going to Glasgow," like, "Oh, you know, is that not pretty rough?" You know, and yeah, it's every inner city is rough, but there's lots of people keep mentioning the stabbings, and there's been some really interesting stuff happened in Glasgow. So Glasgow used to have a huge problem in knife crime, but they did a lot of really good work over the 80s and 90s, and it's still going on now, where they stopped treating it so much as a criminal problem and started seeing it as a public health problem, and started doing a lot of research into, well, why are people carrying knives? You know, why do the young men feel the need to have a knife in their pocket? Well, because people carry knives generally because they're frightened. So why are they frightened? And trying to see it more of a sort of educational and a public health problem, rather than just sending loads and loads of coppers to arrest people for carrying knives. Just try and work more on why people were carrying knives.
Root cause analysis, right?
Completely root cause analysis. And actually, the rate of knife carriage in Glasgow has plummeted, and therefore the rate of stabbings. You know, if you chat to some of my colleagues who've been there a long time, they say in the 1980s, if you did a shift in Glasgow Royal Infirmary Emergency Department, you would see 4 or 5 stabbings on a Saturday night. You know, I would say it's now back to, it's pretty much the same as any big city. In fact, probably less than you would see in certainly some of the major English cities. So, I mean, yes, you do still get people getting drunk and bopping each other, but you don't see the same level of knife crime and same level of interpersonal violence as you used to see years ago. So I think Glasgow's improved enormously over the years. It's still got rough bits, but you know, everywhere's got rough bits. Like I say, the comedy value of the people just makes up for it.
Yeah, I love Scotland. Well, like I said, my man's Glaswegian, and then got friends near Edinburgh, and I do love going up there. But it's just interesting on the knife crime piece. It's like it's sort of the knife crime, that violent crime. It's like a staple of gang culture, isn't it? But with Scotland or with Glasgow, when it was at those extremes, it must have been a case of it wasn't just in the gang culture. It was just that was the default. That was the default method of going, instead of going and filling someone in who you had a grievance with and fucking hitting them. The default was, no, go and stab them. Yeah, that's frightening. Yeah. For it to become normalised like that.
Yeah, and that's definitely a problem in a lot of the gang, inner city gang culture. You're right. That's how you deal with some sort of disrespect thing. You deal with somebody permanently. And it's pretty awful, some of the things that people do to one another. I worked in Washington, D.C. I did some trauma surgery over there a few years ago, and there was a thing where what the gangs would do is stab people in the neck with the idea of trying to paralyse them.
Oh my God!
Which is just horrendous. But the sort of the idea you have to, obviously someone sat down in the cold light of day almost and thought, what's the most horrendous thing I can do to another person? There's a few other things like that people do, and you think, God, what is wrong with people that they would. But the thing is, I suppose it's not. I suppose people are the products of their environment, and I suppose that's the other problem, isn't it? It's chronic poverty and sort of lack of other life choices give people the feeling that they're trapped and they've got no alternative. I don't know. It's difficult. I think the trouble is, a lot of this is easy to say, oh, just lock them up for longer. But I'm not convinced that's necessarily the answer. I think these, like all these problems, there's so many complex causes to it that you can't just, one simple solution will never fix everything.
Mm. What was DC like? Were you in a hospital there?
Yeah.
Talk to me about the experience there in DC compared to here. And America being a country where they don't have access to free national health care. They have to pay for whatever they're going to get treatment for. What was that like? What were the patients like?
So,
was there a difference in attitude?
I mean, I suppose I should caveat saying I was a medical student at the time, so I had a slightly different experience. Yeah, I mean, it's weird. The big things, you kind of think that everyone speaks English, so it's kind of going to be the same, but there's a lot of strange cultural differences, like the hospital security guards have got pistols, for example. Our hospital security guards are great guys and girls, but, they don't have pistols. So it's I suppose that element of, gun pervasiveness, I think in the UK, I'm trying to think back, I think probably in nearly 20 years in emergency medicine in the UK, I've probably seen only half a dozen shootings. It's really pretty rare in the UK, whereas over there, it was twice a night. So there's a lot more shootings. I suppose the other big thing is there. You're right. Medical care over there is all private, so everything comes through a lens of what people can pay for, and that's really. I mean, they're talking about the guys getting paralysed there. The idea of being a young guy with not much money in America and being paralysed just sounds horrendous, because if you think about the amount of care someone who is paraplegic or quadriplegic will require in terms of kit, equipment, training, therapy staff, all of these things. In the UK, that just comes, we just take it for granted.
And over there, they won't get that unless they pay for it, right?
I believe so, yeah.
And a lot of people haven't got health insurance, have they?
Yeah.
Crazy.
I think there is some state funding for healthcare. I don't think it's quite as simple as you just get left to bleed to death in the streets. I don't think it's quite that bad. But yeah, definitely, if you've got chronic health problems or if you've got complex health needs, and you've got no health insurance or no money to pay for it, then people are left to manage these things on their own. I mean, you hear stories like, for example, insulin, which diabetics need to live. In the UK, if you need some insulin, you go and see a GP or your diabetic nurse. You get a prescription and you take it to the pharmacy. And there you go. You might have to spend a couple of quid, but when you're having to spend over 100 quid a vial, if you haven't got the money to pay for that, then you're really going to be in trouble. So a lot of problems with managing these chronic diseases happen because people don't have the money, and they're constantly thinking about not how am I going to stay healthy. It's about how am I going to afford to stay alive, which I think is really, it feels really sad to me. But then I suppose I've grown up in a culture where healthcare is something we just see as something normal, that we all pay for one another's healthcare, and that's just a sort of given in our country.
What was the was there a noticeable difference in the interpersonal relationships, interaction between the patient and the healthcare professional compared to over here? And the reason I say is, over here we go in and we are getting given that for free, right? But if I was going in and it was I may have in the back of my mind, I'm paying for this. So I tell you what, I don't like the way you're speaking to me. I don't like the way you're treating. You could absolutely be a bellend, couldn't you? You could be treated to a bellend.
I think certainly in my experience that wasn't a problem. But I was doing trauma surgery, so almost everyone I'd seen had been stabbed or shot, so it was a different interaction. But I believe because obviously we deploy with Americans, and I've had quite a lot of good chats to them over the years. I mean, they're interesting working with American military doctors because they still work in military hospitals, so they have a very different exposure to this sort of stuff. But yeah, if you chat to the guys who work in the private sector, absolutely, their patients are paying customers, and sometimes they'll come in and say, "This is what I want, and I'm paying for it, and if I don't get it, I'm not going to be happy, and I'm going to."
Oh, that's the other thing. Yeah, they'll come in and choose the drugs, right?
Yeah. I mean, that the idea of that is mental to me, but they definitely. But to be fair, there should always be a negotiation. It's not just about me doctor give, you patient take. There's always a bit of you come to me with here's what I want, and I'll say, well, here's what I think you need, and you kind of meet in the middle, shouldn't you? That's how it should be. It should be a negotiation, a discussion, not just me in the white coat says you get this. But definitely, it shouldn't be the other way around. Going, I saw an advert for this drug on telly, and I really want it. I think there might be a bit more to it than that. But again, that's not really a big problem in emergency medicine. When you're sort of lying there with a broken leg, you don't say, "Oh, I saw this great advert for ketamine. Can I have me some of that?"
No, you get your leg mended and then you read the bill coming to the door, don't you?
Yeah.
How does that work? Do they get billed in hospital, or does it get posted home? What happens?
I genuinely don't know. I mean, you occasionally see online people posting literally the bill they've been sent for their hosptal stay.
Tens of thousands of pounds.
Hundreds of thousands of dollars for what we would regard as. I mean, when I was 17, I had my appendix taken out. Wasn't very nice, but it was done and dusted. Yeah, over there, you get your appendix taken out, and 3 days later, you got this colossal bill if you haven't got a way to pay for it. I mean, I believe, again, I'm not an expert, but I believe it's quite a common cause of bankruptcy. Is people get medical bills they just can't pay, and people lose their houses over it, and all sorts. It's I suppose it's a cultural thing, isn't it? We've decided as a society that healthcare is something that we're all gonna club together to fund, so that no one should feel that they can't get the healthcare they need. It's not a perfect system, but I think it's a lot better than the alternatives. Be interesting to see how it changes.
Here, why would it?
Well, you do
don't
see a
say
lot,
things
a lot
like
more.
that. Why would it change? Don't say that.
I don't think it's going to change completely, but I think you do see there are elements of private sector involvement in more of the health system than there have been, and that's been coming in slowly over the last 20 odd years. Some of it's good, actually. I mean, some of it does give people a better choice and better options.
Give me an example.
For example, an example would be I worked in Sunderland hospital. I did intensive care up there, and they contracted in their X-ray reporting system. So if I as the intensive care doctor, if I organised a CT scan at 2 o'clock in the morning, it wouldn't be rather than ringing in one of the hospital radiologists at 2 o'clock in the morning to tell me what the scan showed, they would put it onto a web server and send it to Australia, where there was a private company that had an Australian radiologist who was up and anyway, he was just reporting. He would report the scan and then tell me what it showed. So actually, it was probably more efficient because it meant that the Sunderland radiologists weren't being woken up at 2 o'clock in the morning, so they could do more during the day. So it was probably a more efficient use of resources and time. So that sort of stuff I thought was quite positive. But equally, sometimes, if, as you say, if you go too far down that road, you end up with it being about profit, not patients, and that's the point where I would be less happy.
And that's the challenge they got in the States. They were on about, I mean, the Obamacare was the famous one, isn't it?
Yep.
But even if they're having to wrestle in order to bring something like that in, something like what we've got in, because Canada have got national healthcare, right?
I believe, and again, you're no expert here, so I'm happy to be corrected, but I believe they have a combination of things. So partly private, partly. So I think you pay a proportion of the costs yourself if you can, but I think there is more support. If you've got no money, for example, I believe that the state does help you. And the Americans do have some of it, but it's definitely not as comprehensive as it is elsewhere. But I think the Canadians do have a sort of hybrid model, and I think that's also what you get in a lot of European places. A lot of European countries have a partially state, partially privately funded system. I don't know. I've never worked in it, so I don't know if it's better or not.
They're trying to. Well, it doesn't sound like it is. I mean, just looking at it, like the national stress levels of an average in America would be they would be less if they didn't have to worry about paying for the medical bills. I look at it like at that high level. It's like just that little aspect of it. But if they ever wanted to try and switch to a model like what we've got or other countries have got, as you alluded to there, the profit, they are wrestling against big political players,
huge political players, and also a huge cultural thing. I think it's not just about politics. It is about culture. I think the Americans have very much sort of individualistic culture than we do. So they would, there is a thing about they would rather sort of stand or fall on their own. That rugged Western individualism thing that means that it's more attractive to them, the idea that they'll do or not do by themselves. So I don't know that it's not just about. And you're right. They would have to make a sort of decision as a society that they're going to have to pay a lot more tax as a group to fund all this healthcare, and it would also change the way they do healthcare. I mean, they spend a fortune on healthcare. They spend more than anybody else per head of population, but it's sort of unevenly spread, and in some ways probably not most efficiently used. And as you alluded to, it's about people. Because it's a private business, people do what brings in the money. So, when I worked in the States, for example, they were very much keen to do imaging, even with the risks that involved, because the risk of missing something was seen as unacceptable. Because if you got sued for missing something, you couldn't afford to defend it. Whereas I think we've been slightly protected from that in the UK. Generally we have a slightly more realistic attitude, because the trouble with medicine is everything's risk. There is no safe path. There's no easy path. Everything involves balancing risks of investigation, risks of not investigating. It's all really, that's why, as I said earlier, it should be a negotiation. It should be about what the patient wants, what we think is appropriate, and sort of meeting. And for most things, you meet in the middle about, you make a plan together. And it's a lot easier to have that negotiation if people aren't necessarily sweating about how for the doctor. I'm not sweating about the more scans I do, the more I get paid. Therefore, there's an incentive to me to do that. And the patient's not sweating, thinking the more scans I get, the more I have to pay for. Therefore, I don't want the scan. There's a tension there that's sort of removed from our system, which I think I don't know. It's never going to be perfect, but I find the conversations a lot easier when it's clear that I've got no. I don't get paid any more for organising a scan or doing anything else. I get paid the same, so I've no vested interest in it. My job is to use the resources as efficiently as I can for all the patients in front of me.
Yeah, it's a good point. It's like that the pharmaceuticals interest over in the States in bringing on GPs on the side, buttering up GPs, so a GP is more inclined to prescribe this drug because they'll get a financial incentive for providing this drug over a competitor, this drug. And then that has to, in a lot of cases, compromise the GP's sort of ethical moral standing in how they're treating a patient. It must be incredibly tough.
Yeah, I think so. I mean, I think people will claim it doesn't affect the decision making, but I cannot believe it doesn't. If you know that you're going to get an extra £100 in your pocket for choosing one over another, subconsciously, even if you think it's not. I mean, so my dad's a retired GP, and the system's changed. But I can remember the drug reps used to come around and they would give little toys and a pen. It was all we loved it as kids because we got like free toys and it was really cool. But even that's gone now. You don't even get free pens from drug reps, which is probably right actually. I think even little things like a pen. If you're carrying around a pen with a drug name on it in your pocket, subconsciously every time you write something, you're thinking about it. So I think actually, whilst it's a shame that I don't have to pay for my own pens, I think I can probably suck that up for the fact that I know that my decision making. I suppose again, I work in a world where I don't prescribe anything expensive. Everything I do is fairly cheap and fairly. There's not really much complicated new medicines. Most of the learning in our world is about how you make decisions and how you implement the stuff that we do, rather than necessarily brand new drugs. But it does happen every now and again.
We need to start wrapping it up. What have we not covered that you want to cover?
Oh, I'm trying to think now. I think we've covered most of the stuff that I think is of
it's been a good chat, mate.
Yeah,
it's been a good chat.
We went down a bit of a rabbit hole on the America stuff, but that was it was interesting. It's it's such a different system. I think like I said before we chatted. I mean, the thing I wanted to sort of chat about was about how where the secondary healthcare, the hospital specialists in the military are, what we're doing. And I think mostly to sort of make sure that people know and understand that we are still there, even in the post-Afghan era. That if people need us, we're still there for them. Even though most of the time we're in the NHS, but that's good. We're keeping ourselves fresh, current, and able to give the soldiers, sailors and airmen the care that they deserve. Hopefully they'll never need it. Like I said, ideally you want your medics to be sat around arguing about who's got the best gadget for brewing coffee. That's exactly, when we're deployed, that's definitely, we do spend a lot of time on coffee. But that's fine. That's what you want us doing, because ideally we'll go away, drink a lot of coffee, not do much else, and come home again. But we're there if we're needed.
Yeah. Mate, it's been an absolute pleasure. I've learned a lot. I've learned a lot.
That's all right. Thank you for having me. It's been a good chat.
No,
It's been good to come up.
How do people get hold of you? Want to get hold of you?
I'm on Twitter. I think it's Ross_Moy, so you can go through. That's probably the easiest way if people want to look me up there that way. And yeah, I say hopefully you'll never see me professionally. That would be.
And good luck with the move to Glasgow. Good luck in the job.
Thank you very much.
Cool. And next time you're back down, we'll get a beer.
Sounds good. Look forward to it.
Cool. Mate, it's been a pleasure.